Welcome to this explainer. Today we're tackling the perinatal journey, and we're looking at it through a really specific, highly critical lens. We're merging comprehensive obstetrician and pediatric clinical documentation with the strict, newly updated 2026 AHIMA and ACDIS Clinical Documentation Integrity, or CDI query guidelines. Now, you might be wondering, why does this matter? Well, because capturing the sheer complexity of patient care, from the first trimester right through to a newborn's first cry, isn't just about practicing good medicine. It's about defensible, compliant, and totally accurate documentation. So, if you want to master how to bridge clinical care with compliance, you are absolutely in the right place.
Okay, let's dive into this by mapping out our chronological patient journey. First, we'll hit prenatal diagnostics and labs, then psychosocial health and screening, followed by elements of delivery notes, postpartum notes and validation, and finally, initial newborn physical exams.
All right, starting off with Section 1, prenatal diagnostics and labs. Now, what's really interesting about the start of prenatal care is the sheer volume of data collected right out of the gate. Every single data point sets the baseline for the entire pregnancy's risk profile. And timing? Timing is literally everything here. Between 9 to 14 weeks, you've got the first trimester screen, looking at key pregnancy proteins and hormones like HCG and PAPPA. Then, windowing into 15 to 22 weeks, the quad screen is offered to assess for things like neural tube defects. Fast forward to the home stretch, roughly 34 to 38 weeks, and we're screening for Group B strep. Missing these timeline milestones in your documentation basically means you're missing the full clinical picture of the pregnancy.
If we break this testing down, we're essentially managing two distinct tracks. On one hand, you have the routine lab panels. This is your ABO and Rh blood typing to check antibody status, a full suite of STI screenings like syphilis, HIV, and Hep B, and of course, that Group B strep we just talked about. On the other hand, we have the targeted genetic and aneuploidy screenings, like the ultrasound nuchal translucency. The major takeaway for us? It's making sure these results are explicitly tracked and followed up on in the chart. A compliant record isn't just a receipt showing a test was ordered. It actually documents the result and the clinical decision-making that followed.
Moving right along to Section 2, Psychosocial Health and Screening.
Psychosocial health is a critical, though honestly sometimes overlooked, part of prenatal documentation. The data clearly shows it's vital for both maternal and fetal well-being, so the documentation here needs to be incredibly precise. For instance, take intimate partner violence, or IPV. It has a known increased incidence during pregnancy. Because of this, screening has to be documented at several distinct milestones: preconception, the initial visit, at 28 weeks, and again in the postpartum period. We also have to consistently capture tobacco, alcohol, and substance cessation counseling. And for maternal mental health, the use of standardized, validated tools like the Edinburgh Postnatal Depression Scale, the EPDS, must be explicitly documented. The EPDS literally only takes about 5 minutes for the patient to fill out, but its impact on the documented risk and the subsequent care plan is just massive.
All right, let's step into Section 3, Elements of Delivery Notes.
This is where we build up the narrative tension toward the main event, the delivery itself. The meticulous documentation required immediately post-delivery is where a huge number of compliance gaps happen, mostly just due to the fast-paced, high-stress nature of childbirth. To anchor us in everyday practice, think about a standard electronic medical record interface where all this rapid-fire delivery data gets logged. A provider is managing a highly dynamic, frequently emergent clinical situation, yet they have to accurately capture a ton of specific elements into the EMR to meet the standard of care and support coding. It's a heavy lift for sure, which is exactly why structured templates are an absolute lifesaver.
So what exactly goes into that critical delivery note? The absolute bare essentials include gestational age, the mode of delivery, ABGAR scores at 1 and 5 minutes, and the birth weight. But you also need the granular details. Was the placenta fully intact upon delivery? Was there a 3-vessel cord evaluation? Were there any lacerations or an episiotomy, and how exactly were they repaired? And crucially, estimated blood loss, or EBL. This last one is a massive focal point for CDI specialists. An accurate EBL is basically the gateway to properly diagnosing and validating bleeding complications.
Let's move to and see how this builds into Section 4, Postpartum Notes and Clinical Validation.
When analyzing the postpartum period, we usually break it down using the classic SOAP note structure. And this is where the concept of clinical validation truly steps into the spotlight. Step 1 is subjective, so checking the patient's pain levels, lactation success, and voiding. Step 2 is objective, looking for specific clinical indicators like fundal height, uterine tone, the character of the lochia, and perineal status.
Step 3, the assessment, identifies the actual clinical problems. And Step 4, the plan, wraps up with contraception and follow-up. But here is the million-dollar question for compliance. What happens when the objective findings in Step 2 just don't clearly support the diagnoses listed in Step 3?
Well, that brings us straight to clinical validation. According to the foundational 2026 AHIMA and ACDIS guidelines, clinical validation is defined as the process of ensuring that a documented diagnosis is supported by objective clinical indicators within the health record. Basically, it is not enough for a provider to simply write a diagnosis down. The clinical indicators, say a boggy uterine tone or specific drop in lab values, must actually be present in the chart to support it. If they aren't, a query is required.
And this brilliantly illustrates exactly what you should and absolutely shouldn't do when querying a provider under these 2026 rules. Let's look at a non-compliant query first. The EBL was 500 milliliters, please document postpartum hemorrhage. Okay, that is a classic leading query. It is telling the provider exactly what to write, which is a massive compliance violation. Now, contrast that with a compliant query. Given the boggy fundus and HGB drop from 11 to 8, please clarify the diagnosis: A, postpartum hemorrhage, B, routine EBL, C, unable to determine. This is perfect. It gives the provider the clinical indicators sourced directly from the chart, offers non-leading options, and importantly, it includes that mandatory unable to determine option so the provider can exercise their independent clinical judgment.
Finally, Section 5, Initial Newborn Physical Exams.
Transitioning our focus from the mother's record to the infant's chart during those critical first 24 hours of life, we rely heavily on two major scoring systems, and they serve very, very different purposes. The APGAR score evaluates the immediate normal infant transition to extrauterine existence at exactly 1 and 5 minutes post-birth. Think of it as a rapid-fire status check. The New Ballard score, though, is a much deeper assessment, usually done within the first 24 hours. It combines physical characteristics with neuromuscular development to accurately rate the infant's gestational age.
So you absolutely have to know exactly what makes up these scores so they can be documented perfectly. The APGAR test uses 5 specific parameters: color, heart rate, irritability, tone, and respiration. Each one gets a score from 0 to 2. So, a baby with a heart rate over 100 beats per minute, active motion, and a good strong cry is transitioning well and will score a 2 in those categories. If the documentation in the chart simply says APGAR 9 without actually specifying these individual parameters, you are missing the granular clinical indicators that paint the true, defensible picture of that newborn's very first moments.
Which brings us to the end of our explainer journey today and leaves us with a somewhat provocative question. Are your clinical queries as healthy as your patients? We've walked through the meticulous documentation required from the very first prenatal visit, right through the chaos of the delivery room and into early newborn care. We've seen how the strict 2026 AHIMA and ACDIS guidelines demand that every single diagnosis is backed up by rock-solid objective clinical indicators, without ever leading the provider. It's a high bar, no doubt about it, but it's exactly what ensures accuracy, fair reimbursement, and true integrity in healthcare. I challenge you to take these guidelines and apply them rigorously to your own charts today. Thank you so much for joining me, and please like, share, subscribe to Decode Healthcare with Harshal.